Good evening, everybody. Today we will be discussing the placement of ultrasound-guided peripheral IV access, or USG-PIV. My name is Michael Kiak. I'm a student here at Drexel University, and I hope you all find this topic to be interesting. Some of our course objectives are listed here. So at the end of this session, the attendees should be able to compare personal knowledge regarding IV placement, recognize patient population and indications for ultrasound-guided IV placement, differentiate between the anatomical landmarks and site selections, identify materials needed to successfully attempt an ultrasound-guided IV, and demonstrate a placement of an ultrasound-guided IV under the supervision of a certified ultrasound-guided IV RN. Now, at the end of this, we will be doing this demonstration on patients, real patients. So for the sake of maintaining HIPAA, unfortunately, we will not be able to film these activities, but they will be well documented. So let's take a moment here. We're going to take about 5 minutes and break out into a few groups. What I would like you guys to do is discuss your experiences with standard IV placement, not ultrasound, just standard IV placement. And I want you to have somebody to document your answers and then present them once you guys are done breaking out in the groups. And these are the 3 questions that I've conjured up here. So what challenges have you faced with standard IV placement? What type of patients were these? And did you end up having to obtain access under an ultrasound from a provider or from another nurse who's ultrasound guided? So go ahead and take a minute and break out into those groups, and I'll see you guys in 5 minutes. Okay, and we are back. Some very interesting answers that you guys had for us here. So let's go ahead and we'll continue on. So patient populations who require ultrasound-guided IV access typically have no visible anatomic landmarks for standard IV placements. While these pictures are a bit grotesque and a little bit disturbing, you can see on the right there that is a patient with +4 pitting edema, and the patient on the left there is, we'll see on the next slide, an IV drug user. So you can see that these patients are obviously not super easy to get standard IVs on. So let's give a few examples of those patients. So as we saw in the previous, the edematous or obese patient, they typically have more subcutaneous tissue or more extravascular fluid on board, making it difficult to see those veins even with a tourniquet on. Your end-stage renal disease patients are typically vasculopaths with other comorbidities, which make it extremely difficult, or they have veins that blow very easily. Your oncology patients typically are difficult sticks as well, as they've gone through rounds of chemotherapy or radiation, making the veins a bit more friable and a bit undetectable to the naked eye. Your IV drug use patients, similar to the one that we saw in the last picture there, because of wounds, because of previously blown veins or infections in their arms, also very difficult to obtain standard IVs. And severe critically ill patients. Unfortunately, these patients third space shift a lot of fluids. They are on quite a bit, depending on the severity of their illness, quite a bit of vasopressors, which essentially clamp down their veins, making them smaller. And with the edema and fluid redistribution, intracellular or intravascular to extravascular, you tend to get quite a bit of difficult time getting IVs on those. So these are just some examples of patients who warranted ultrasound-guided IVs. Other indications for ultrasound-guided IVs. Additionally, patients often require ultrasound-guided IV placement if 3 unsuccessful attempts at standard IV placements were attempted. So these are the patients, again, you think maybe they have those veins that really pop while they're under a tourniquet. However, maybe they have valves, maybe they're just rolling away from you, maybe they're a little dehydrated. So if the patient, you stick 2 times, you try that last time, and they're saying, look, typically for patient satisfaction purposes, we'll say, all right, let's get somebody with ultrasound experience and, attempt to get a better access on them. And again, a patient does not tolerate multiple attempts at standard IV placement. I put in quotations here. Ultrasound-guided IVs increase patient satisfaction by decreasing the number of sticks. Most patients, when you walk into a room, if they know they're a hard stick, not really a point in trying to get a standard IV placed on those types of patients. These patients typically just grab somebody who's ultrasound-guided IV trained and make them happy, because patients come first and their outcomes mean better results for the hospital, the health system. Site selection. So before the ultrasound is used, you want to be sure to ask yourself why and where. So why does this patient warrant an ultrasound-guided IV access? Look at the patient, assess them, go up to their arms, their hands. Are they edematous? What's in their history? Are they a difficult stick? Do they have renal dysfunction? All of the things that we cited on the patient populations that require ultrasound-guided IVs, these are important things to look up before you walk into a patient's room or while you're getting a report on your patient. So in the back of your mind, you can think, all right, so maybe I'm not as good at free sticking, so I should get somebody with an ultrasound-guided IV skill and get in there and get access on them. And where is the best place to stick them? So typically, and we'll discuss this further down the line here, but typically you want to start at their AC and work your way down their arms if they have the available vasculature. This here is just a picture that sort of goes over the anatomical landmarks. What I liked about this picture is it actually has images, real live ultrasound images of these vessels. One thing I wanted to touch upon here is the image here with vein, and artery. Typically when I am demonstrating or teaching somebody for the first time, I always say, look for the Mickey Mouse ears. So you see the small head and the two Mickey Mouse ears, or the three bubbles. Typically when you see this complex of the artery, vein, and vein, be sure to compress hard with your probe, because the artery will typically be pulsatile even though it collapses, and the veins will just collapse. This is a good way to differentiate between artery and vein before you go ahead and stick. I run upon many cases where you go to draw blood from a peripheral IV and it looks pretty bright red, and you can sometimes see pulsatility in the pigtail on that IV. And this is concerning because that's, that is essentially a capped arterial line that's placed in the patient. And a way you can differentiate arterial versus venous, draw blood gas on it, send it to the ABL90 machine and see where their PO2s are. If it looks bright red and pulsatile, it's likely in the artery. So obviously you have to take that out and report the incident. So where do we start? So superficial and distal. As I said before, we start right at the AC and move our way down. So you want to begin by searching for a superficial and distal vein to preserve proximal deep veins. Remember, the PIC team, they need lines, they need vessels up above that AC point. So if we're constantly poking those veins, you're adding scar tissue, you're making the vein more friable, you're transfusing medications that can be sometimes vesicants that can disrupt the normal function of those healthy veins for patients who warrant a PIC line or a midline. So again, lower down on the bottom part, preserve the upper veins there. And again, place your probe to the AC, as we said, and move the probe away from the body and toward the hand. That is the gold standard. Obviously, if you can't find anything and you have to go further up and the patient is critically ill and needs more access, whether they need their central line out, whatever it may be, then run that by the provider and see if it's okay to stick further up in the arm. Things to avoid. You want to avoid the basilic cephalic vein if 5 things here. If their creat is greater than 3, you want to avoid this vein, obviously, because this patient may require some type of access for dialysis, or you may want to preserve those vasculature for an AV fistula. If there's current or prior hemodialysis, obviously, in those arms, you shouldn't be putting an IV in the same arm as an AV fistula. If they've had a prior kidney transplant, again, probably dialysis player, likely a vasculopath. If they have known superficial clots, so if they're holding anticoagulants, they're a post-surgical patient not on anticoagulants for post-operative bleeding, but you know that they're at risk. And sometimes you can actually visualize clots with the ultrasound machine. So if you know that there's clots in the arm, it looks more red, it looks more edematous, looks more swollen, they're complaining of pain in that side, just avoid it and look on the other side. And also if they've had a mastectomy on the same side, any patient with a breast CA history, always be sure that there was no lymph nodes, mastectomies, things removed from that arm, as we like to avoid placing IVs on those arms because of the disrupted anatomy above. One last thing, when you go into your patient's room or you're checking the chart on your patient, I started this, check the chart or the patient's wrist for a limb restriction band, especially, again, all of these reasons here. Specifically in like mastectomy patients, you always see that pink limb restrict band. Don't stick those arms unless it's emergent or unless otherwise noted by the physician. So differentiating veins from other structures. So we created a table here that kind of go over the colors that you'll see under ultrasound, the compressibility, the pulsatility, and the thickness of the walls. So not really super focused on the nerves, but sometimes they can be confused with veins. I'm looking more at the artery and the vein. But if we're looking at the nerves, they typically show up like a brighter white on the ultrasound screen, depending on the angle. They are not compressible, which can be an indication that, all right, if it's not compressible, we're not going to stick because A, it's either a nerve, or it could also be a clot. So anything that lacks compressibility, don't stick it. Pulsatility, none. Obviously, it's a vein. It's not, no blood flow through there. And then the walls are bright as well. So these are those bright white circles. Your arteries, they tend to be a darker black. They are compressible with pressure if the patient's hypotensive. Obviously, they're not going to be getting that cardiac output as well. So their vessels, again, their arteries may be a little bit more compressible. But hold down and be sure you pay close attention to see if, yes, they're pulsatile, because 90% of them are. And these walls, a little bit brighter and thicker. So if you're ever confused, find another vein, look for the thinner wall versus the thicker wall. That's kind of a thing. And again, like I said before, those complexes, the Mickey Mouse ears, look for those as well. And then our veins, they're going to be hollow black. They are going to be very compressible, except, again, when the clot's present, almost looks like there's like a little nerve running through it because it's very bright in the center. They do not have pulsatility. Sometimes with a tight tourniquet and a bit of venous congestion, they cannot be as compressible, but they won't be pulsatile regardless, and their walls are a little bit thinner. Ultrasound basics. So when we're talking about depth, when you place your probe on that arm, you're going to see on the side of your screen, you're going to see the depths. And this is measured typically in centimeters. So this can be adjusted to user preference. And veins deeper than 2.2 centimeters are poor candidates. Because if you think about how long, which is usually 1.88 inches, that catheter has to go through skin, tissue, and then into the vein. By the time you're getting to the vein, typically on a very edematous patient or a morbidly obese patient, by the time you get to the vein, there's only a small little bit of catheter that's actually intravascular. So you want to try to avoid those deep, deep veins if you can. Now again, in an emergency, temporary, as long as you confirm that that IV is in the appropriate vein. So again, adjusting the depth to your preference, and it can also give you a better view if you adjust the depth down. It kind of zooms out on that image, and we'll go over that during the demonstration. Ultrasound basics again. So when we talk about gain, so this isn't a vascular image here. This is a different type of image. This looks like a liver actually, but it was a great example of the gain settings. So when the gain is essentially the brightness of the image, which can be adjusted to user preference, obviously. However, when you put that probe on and you see kind of dark gray shadowing, you can kind of tell that that's too low of a gain. So go ahead up to that machine, crank that gain knob up. Sometimes there's a little bit of a delay and it'll bump really bright and really high, so you just have to dial it back nice and slow and get your appropriate gain setting. So again, the depth and the gain knobs, those are two very key important things to get a really good image of your catheter going into the vein and to get a really good image of the vessel that you're intended to stick. More ultrasound basics, the center line. So there is a center line that runs directly down the screen that corresponds with the arrow on most, if not all, vascular probes. There's a midline as well, or M mode. We don't want to use that. We want to use the center mode. It just makes it a little bit easier, and that M mode can sometimes black out the image on the screen a little bit. So the center line of the linear probe corresponds with the center of the screen. I also want you guys to take note that on most vascular probes, actually if not all, you can't really see it here. If you look closely in this image, there's a small little notch. It's called the probe marker. And then on your screen, you'll typically see the blue dot, or it can be a white dot. And you can adjust that left to right, user preference. But that dot corresponds with that little lip, the small lip on the side of the ultrasound probe. It helps to get you oriented when you're sliding that probe left and right or fanning it forward and backwards. So just keep that in mind. More ultrasound basics, so we're talking about probe techniques here. So you won't necessarily use all of these right in the beginning, but they're just some things to familiarize yourself with. So there is sliding, there's sweeping, there's fanning, and rocking. The probe will enhance, doing this with your probe will enhance your view of the needle tip, and the vein. So when we're thinking about sliding, we're going along that y-axis. Your probe is basically cutting, through from side to side. This is along the axis of the probe across the body with consistent angle of inclination at 90 degrees to the target. So keep that right upright and go right along. Because you remember, ultrasound is essentially bouncing through and coming back up. The image is cutting right through that arm. Rocking, so we're going, while you're remaining flat at 90 degrees, you're just tilting it on and off. For patients that are a little bit smaller with more round arms, this can kind of help you visualize the vein a little more. Sometimes you have to rock back and forth to get more of the vasculature image in your view on the screen. Sweeping, so sweeping is also, sliding and sweeping are the two big ones. Sweeping is that motion of coming from the AC down to the hand or coming from the hand back up. And this technique is very important for finding your needle tip if you ever lose the needle tip. And then there's fanning, not overly important, but it is important, but a little bit more of a higher skill level technique, kind of tilting it, along that x-axis, but front to back there, again, can give you a little bit more of an image. Sometimes the gel in the gel probe can bunch up to one side, and by fanning it up and back, you can actually get a better image. Pressure and compression, very important, again, for differentiating between an artery, vein, or nerve, but mostly for the artery and vein. It's push down and compress. That's crucial for finding, you're differentiating between the vein and artery. And then there's rotation. Again, this is more of an expert technique here, whether you're going transverse or longitudinal. People can hit a longitudinal view a little bit better. It's more for providers, and I've seen nurses do it, but for right now, we're gonna avoid doing rotation, and we're just gonna stick to the slide, the sweep, and the pressure and compression. So at this point, I'm gonna start with, so this is the gathering materials section here. This will kind of be this is the intro to our demonstration here. So I'm gonna go through all of these, but this is also what I want you to pay really close attention to, because this, starting from here, is what we are going to be doing once we get to the patient's bedside, okay? So when we walk into that patient's room, hello, Mr. and Mrs. So-and-so, my name is Mike, I'm gonna be your nurse today. I understand that you require some IV access, and I'm going to attempt so with an ultrasound. Do I have your consent? Ask if they're okay, establish that trust right off the bat, and then we're going to gather our materials. So before placing that probe on the patient, you want to gather the ultrasound machine with the linear transducer. Now be sure that it has the linear transducer. Some of the sonocytes that we have on this unit, they will pop the probes off and bring them to another one, and they'll only have, one of the other types of probes on there, not the linear transducer. So be sure that that's attached there, and if it's not, find another machine. You want to get your gloves. You want to get a probe cover. These are typically packaged with sterile gel. Some are packaged without the sterile gel. So if not, you can find the sterile gel at the bedside. You want to get an IV starter kit with a normal saline flush. I typically pair those two, and then I'll grab a pigtail as well. Some people like to use the just the standard stems. I know in the emergency department they use the stems over the pigtails. I personally like the pigtails. Again, you can get that view. If God forbid you stick an artery, you can see the pulsatility a little bit better. And you want to get your cleaning agents with that. So a few extra chlorhexidine swabs or alcohol swabs. Keynote here, I want you guys to check the patient's chart, because some patients do have chlorhexidine allergies. Just be sure that that's not noted in their history. And you can clean with other things. You can use alcohol, or some people can tolerate betadine instead. And then you want to get the appropriate length and gauge IV catheter. So any ultrasound guided IV uses a 1.88 inch long IV. And you'll see this listed. The product we use here is a BD product. I don't condone or work for this company, but that's our product here. And they are listed and labeled on the product as ultrasound. And if you're ever confused, hold them together. The ultrasound guided IV, the IVs that are ultrasound guided, the 1.8s are a lot longer than the other ones. Or any vein that is greater than 1 centimeter deep. So select the IV based on the vein diameter. So getting started again, we want to go through the 3 P's. So positioning, probe, and preset. So this is all as you are setting up at the bedside. So obviously plug your machine in, bring it over to the opposing side of the bed. If you're a lefty, you can bring it to the right. If you're righty, bring it to the left. But positioning is important. I want you guys to think ergonomics here. We have the sling lift so we don't hurt our backs. We have other things in place so that we don't get injured on the job. Positioning is very important because you're going to be bending, you're going to be looking, you're going to be sliding, and you're going to be standing still for quite some time. So you want to create an optimal position. So position the machine so that the screen is visible and right in front of you, and you want to maintain a neutral neck position. You don't want to keep it in front here so you're twisting. It's got to be right in front of you as if you are stirring the pot, right in front of you there, okay? And position the bed height to your preference, but obviously you don't want to be bent down. So again, be mindful if the patient has an A-line. When you bring that bed up, or CVP, or any other things that need to be leveled, bring it up, level, and then you can start to prep your patient. And then position the limb, whichever limb that you're sticking, position that in front of you, in a place that's easily reached and easily accessible. And if the patient is not totally with it, or they are anxious and they're restrained, it's okay to ask for help to get someone to hold that limb down. You can also use a restraint to keep them down and some tape to hold that hand in place. It's helpful. It's difficult at first, but it's helpful to talk the patient down if they are getting anxious. Here's what you're going to anticipate. Nice sharp pinch, little poke, cold gel, little swab. Walk through what you're doing. It helps to ease the patient's discomfort. Probe. Again, we're using that high frequency linear transducer. You'll see it written on there when you adjust the settings on the ultrasound machine. You are going to linear transducer or superficial. You will see it on there. And preset, again, we kind of just tied into that. You're going to be using the vascular, superficial, or small parts setting. Some offer the small parts, but 90% of the ones I've used are vascular and superficial, and you'll see those settings. So if it's on, they were ultrasounding someone's lung or heart, you have to switch it over, and you'll hear the click on the machine typically. And you want to consider the needle guide setting if that's available. I've never used that before, but some of the machines do have that as well. All right, prep the probe and the site. So once we have set everything up, your ergonomics are to your standards, we are going to go to the patient and we are going to prep them and we're going to probe them. So before we apply the sterile gel, we're going to wipe them down. We're going to get that chlorhexidine swab, that alcohol swab, or that betadine. We are going to wipe that arm down, and we are going to apply sterile gel to the arm and also sterile gel to the probe. You're going to take that probe cover right here. Typically the gel goes on there, and then you carefully place because you don't want to slide all the gel off the tip of the probe. Cover the probe with the probe cover and secure it with rubber bands in the kits. Typically the the kits come with 2 rubber bands, orange, blue, whatever color they are. And if not, you can use some tape. Works just as efficiently. Just be careful you don't go too tight because it gets stuck. And then use appropriate skin prep and clean the intended site, as we just talked about. So we're cleaning the patient, cleaning the probe, we're applying the gel, voila. We move on next. Again, just some examples here. Performing the placement. So, using your probe techniques, I want you to identify a target vessel and proceed using the transverse or out of plane technique. Now, this is that transverse plane, not the longitudinal. So you want to keep that probe perpendicular to that arm, because again, we are cutting right down the arm, and that's what will give you those views as we saw before with the anatomical slide. They'll give you just the circles. When you flip that to longitudinal, you're going to see a bunch of long things, and it's a little bit more difficult. This is the way that I recommend starting. So your probe scanning hand moves through the procedure. You're going up and down. Your other hand, whether you're lefty or righty, will stay snug to that needle or to the catheter, okay? I want you to keep the probe at 90 degrees to the vessel. Again, keep that straight up and down. That's going to give you your best view, unless you need to do some of the other techniques we talked about to get the gel in place. But you want to keep that probe at a 90 degree. And you want to follow the needle tip. So you move the probe away from the needle until the tip disappears, then move the needle forward into the plane of view of the probe. This will all make sense once we start, but again, this is very subtle and fine movements. One technique that I used to, or that I learned over the years, I call it creating the fulcrum. So drummers use their hands to create fulcrums so that their sticks bounce easier. The fulcrum here, you rest your 2 or 3 fingers on the arm of the patient, and you move with your index and pointer finger, almost like you're holding a pen or a pencil. That's the point, the fulcrum at which you're stabilizing that probe so you can do finer, small, subtle movements. It really helps getting a detailed image, and it helps find that tip and take it nice and slow. So that way you're not slipping and sliding off of the arm. It gives you that stability. Sort of like also somebody shooting pool, if any of you have experience there. And then once the needle enters the vessel, you're going to decrease the angle of the needle as it enters the skin, and you're going to continue to advance under guidance. So again, you're pulling away, you're dropping your angle, you're moving that probe away, bringing the needle tip into sight, away, needle tip into the sight. And eventually we move on to getting our flash and getting our everything else completed there. So these are some steps here. You can take a look at these. Take a look at this slide, and actually, I recommend printing this out. This one's multi-step purposes of how to actually go through it. For those that are visual learners, this is great. They call this the creep method, and that's essentially what we were just talking about, those subtle movements. You creep it up, poke it through, creep it up, poke it through, creep it up, poke it through. So this is something to help, review before you go in and stick the patient if you're really nervous or having trouble with it. But really, it's, practice makes perfect. Angle of insertion, as we talked about. So the angle of your probe will sit at 90 degrees. There's a bunch of calculations here, but what I want you to know is the angle of your probe will sit at 90 degrees, and you will typically start to stick a patient at that 45-degree angle. Again, between 30 to 60 degrees is appropriate for most veins, so 45 is the mean there. So stick to 45 degrees. If they are a little bit more edematous, you might want to bring that up a little more so you can get the needle tip deeper, quicker, so that way when you drop your angle, you puncture through the needle and more of the catheter gets into that vein. And then once you are confident the catheter is in the vessel, you're going to release your probe. You're going to advance the sheath or the catheter off of the needle and retract your needle. You're going to attach your normal saline flush with a pigtail or with an IV stem and assess for blood return. Most of the time, people get hung up from doing standard sticks to looking down when they think they're in at that IV and, oh, there's some blood return there. There's some, I think I'm in. But sometimes you're not actually in. You may have actually blown through the vein. So contrary to popular belief, I want you to keep your eyes up on the screen and confirm that you are in on the screen versus with that flash down there first. Then, when you advance the catheter smooth as butter, you'll see that blood flow does come back. I want you also to be careful. Some of the catheters are manufactured with the valves that stop the backflow, and some of those catheters are manufactured without those. So as soon as you release that needle, if you are in a plump vein with the tourniquet up, blood is going to start rushing back out if it doesn't have that. So be ready with your pigtail. Maybe put a little 2x4 or a 4x4 under there, or be ready with your stem cap and your saline flush. Assess for that blood return, then you're going to give the IV a flush and assess for infiltration. You can also, once you get a little bit better at this, you can place the probe back on the arm and flush, and you can kind of see it, the saline flushing through the vein to confirm that you're in. But ultimately, when you give it a flush, do like you would with a standard IV, put your hands up further and make sure that the patient's not wincing, they're not in pain, but also make sure that you're not seeing any signs of infiltration through that site. So once you are all done, and once you've acquired your access and you've attached your pigtail, we're going to go through some site and machine care. So using your IV starter kit, I want you to clean the remaining sterile gel and blood around the site and apply a label to your IV, and then you're going to cap it with a Kuros cap. So the ultrasound jelly can get a little bit sticky. Some facilities offer skin prep, which will help. You want to be sure that it's completely dry and that you've gotten all that jelly off, because if you wipe and you go to stick that dressing on there, sometimes it'll peel away. Another thing to keep in mind, if a patient has excess arm hair, it might behoove you to prep and shave the area first. You can, look for the vein, come back, and then restart the sterilization process. It's okay to, break sterility and then re-sterilize, especially again if they're extra hair on that arm. That patch or that the dressing's not going to stick as well, and it'll hurt when you're pulling it off. So just be mindful of that. And then once you're right here, this is just a great image, and it actually looks like they shaved this guy's arm because he's a little hairy. This is a good image of properly labeled, capped, clamped. Looks like a great IV. Whether it was done in ultrasound, I'm not totally sure, but that's what your end product is supposed to look like. And then ultimately, you want to clean and disinfect your machine after each use. So disinfect the probe, the cord, the screen, and other machine surfaces with appropriate disinfectant wipes, ensuring adequate wet time. So each facility, again, has different products, different wipes they use. Here we have, now we have bleach and alcohol wipes, different dwell times for different products. We'll use the bleach wipes on here. A lot of these are waterproof too, so you can soap and water these first and then bleach them just to be extra cautious. But I always say start at the tail, move your way to the body. Start at the probe, get the cord, and then get the rest of the machine. And then put it back in the storage closet for where it's stored. Some technique pitfalls I want you guys to just be aware of, so not advancing far enough. So this is when the needle tip is in the lumen, but the catheter gets caught in the vessel wall. When you're putting in standard IVs, we all know the feeling of being in the vessel. You get that little flick at the end there. I want you to still feel for that, but keep your eyes on the screen. And again, be careful, like on the screen when we come up to this pitfall down at the bottom. But when you feel like maybe you're in, just be sure, give it a little extra punch or a little poke. Sometimes, again, you get stuck on that vessel wall and it doesn't go all the way through. But be careful if you're at a deeper angle because you can blow right through the entire vein. Another pitfall is not following the needle tip. So this results in visualizing the middle of the needle instead of the needle tip itself. Sometimes that bright shininess on the screen of the needle tip can get lost and you can get a little confused with other anatomical landmarks or other parts of the IV catheter. So this is sort of one of the common reasons, like you think you're visualizing it and you keep advancing and then you eventually blow through the vein. And you'll kind of see that on the screen as you get more advanced. You can tell whether you've blown through the vein. So what to do if you lose your needle tip. If you lose the needle tip, don't advance anymore. I want you to draw your probe back to the puncture site and re-advance to find the tip, the bright spot on your screen. It looks like a little star. So you'll go back, slide nice and slow, and as you're doing that, gently in and out or wiggle the needle tip to identify the tip. You'll see it wiggling inside of the vessel once you identify it on your screen. It's kind of hard to miss. All right, so next I'm going to play a video demonstration. For those of you who have access to this PowerPoint, you can copy and paste it, but we're just going to click on the link here and we're going to watch it. So this is just a simple demonstration from the New England Journal of Medicine. What I want you to focus on are sections 1, 2, 3, 4, 6, 7, and 8, okay? This will be a good kind of preface before we break out and we go and start, poking patients.
This is a video in clinical medicine from the New England Journal of Medicine.
The purpose of this video is to teach physicians, nurses, and other medical providers how to use ultrasound guidance to place catheters in peripheral veins.
That's a longitudinal
Placement of a
view there,
peripheral
guys.
intravenous or IV catheter is indicated for the administration of intravenous fluids and medications. Placement of IV catheters is a fundamental skill that all professional healthcare providers should possess. IV access may be difficult because of obesity, IV drug abuse, the placement of multiple previous IV catheters, and other factors. In these situations, ultrasonography can facilitate IV catheter placement by allowing visualization of veins that are not apparent on physical
Again, longitudinal view, guys. There, that's
It is
more
reasonable to
advanced
use
technique.
ultrasound guidance after 2 failed attempts at standard IV catheter placement.
We
And
used
it may
3
be best
attempts.
to use ultrasound guidance immediately if there has been a history of difficulties with IV access in the patient. We will review the proper technique for standard IV catheter placement and then demonstrate ultrasound guidance. We will limit our discussion to the upper extremity veins, but the same techniques can be used to cannulate any peripheral vein. To find the best site for an IV catheter, it is important to know the venous anatomy. The metacarpal and dorsal veins on the hand are good sites for initial cannulation attempts. The cephalic vein is usually prominent on the anterior radial aspect of the forearm. The basilic vein on the ulnar side of the forearm is often neglected because of its posterior position, but is usually prominent and often larger than the cephalic vein. In the medial antecubital region, the basilic vein is medial and the cephalic vein is lateral. The median cubital vein runs diagonally through the antecubital fossa, connecting the cephalic and basilic veins. Antecubital vein cannulation is common in emergency situations, but not ideal for long-term IV therapy. Proximal to the antecubital region, the basilic and cephalic veins are deeper and often inaccessible without ultrasound guidance. In addition, the deep brachial veins run down the middle of the upper arm, adjacent to the brachial artery. Blind cannulation of these veins has a high complication rate, but they can be safely accessed with ultrasound guidance. Before starting the procedure, collect the necessary supplies. You will need a tourniquet, an antiseptic swab, an adhesive dressing, a needle and catheter, a Luer lock adapter, and a saline flush. The most common IV catheter consists of an inner needle and an outer catheter. Common sizes range from 24 gauge for newborns to 14 gauge for adult trauma patients. Most IV catheters are about 1 inch long, but longer catheters are available for cannulation of deeper peripheral veins. Potential complications of IV catheter placement include phlebitis, thrombosis, infection, ecchymosis, hematoma, and infiltration. Wash your hands and use universal precautions. Apply the tourniquet. Palpate or visualize the vein. Vein should be soft, elastic, and resilient, and should be pulseless. Clean the skin with the antiseptic swab. Stabilize the vein with the fingertips of your non-dominant hand. Hold the needle with your dominant hand between your thumb and index finger. Make sure the bevel is pointed up. The needle approach should be along the course of the vein at an angle of 10 to 30 degrees to the patient's skin. Puncture the skin and then the vein with a quick forward motion so the needle tip penetrates the wall of the vein instead of just pushing it aside. When the needle tip enters the vein, there will be a flash of blood into the catheter. Decrease the angle of the needle and advance 1 to 2 millimeters further to ensure that the entire needle tip and the tip of the catheter are fully within the vessel. While holding the needle still, slide the catheter into the vein. Apply firm pressure to the vessel proximal to the tip of the catheter. Remove the needle and place it into a sharps container. Remove the tourniquet. Place the luer lock adapter on the end of the catheter. Anchor the catheter, adapter, and connection tubing to the skin using adhesive dressing. Flush the catheter with sterile saline. The flush should flow smoothly into the catheter. If there is resistance, the catheter may be kinked, occluded, or outside the vein. Look for signs of extravasation, such as pain, swelling, or blanching. Providers who are proficient at standard IV catheter placement will
And
find it
nurses.
relatively easy to learn ultrasound-guided techniques. Novices need to understand a few basic ultrasound concepts. Ultrasound images are created by reflections of sound waves, so denser structures appear bright and fluid-filled structures appear dark. Changing the gain changes the brightness of all structures on the ultrasound image. Gain should be adjusted so vessels appear black and the surrounding soft tissue appears gray. The ultrasound image plane is several millimeters long in the longitudinal axis and only about 1 millimeter wide in the short axis. By convention, the top of the ultrasound image represents the skin surface and deeper structures are at the bottom of the image. There are centimeter marks on the sides of all ultrasound monitors, so it is always easy to determine the depth. Depth should be adjusted so that the target vessel is in the center of the image. Left-right orientation should also be easy because the symbol on the left side of the ultrasound image correlates with the indicator mark on the transducer. A linear array transducer with a frequency of 5 to 13 megahertz is usually used for ultrasound-guided vascular access. Short linear transducers are made specifically for ultrasound-guided procedures. It's best to place the arm in a horizontal position so the ultrasound images and needle movements are in the vertical plane. Elevate the bed or sit down so that you are not bending or stooping, but working with your hands comfortably in front of you. Place the monitor so you don't need to turn your head or look over your shoulder to see the ultrasound images. There are two commonly used techniques for ultrasound-guided vascular access, the transverse technique and the longitudinal or in-plane technique. Transverse or longitudinal describes the orientation of the ultrasound plane with respect to the vein and the needle. In the transverse technique, the ultrasound plane is transverse to the vein and the needle, so the vein is circular and the needle is a single bright dot. With the longitudinal technique, the long axis of the vein and needle are in line with the ultrasound plane, so the vein appears as a tubular structure and the entire needle is visualized. The transverse technique gives less information, but is easier to learn and is recommended for novices. The longitudinal technique is more difficult to learn, but is preferred by many experienced providers. We will demonstrate these techniques and explain why it is best to learn both, regardless of which technique is used during the procedure.
All right, so we're going to take a pause there. We're going to, the remainder of the video kind of goes over everything that I've discussed before, or towards the end here. Let me just get back. Pardon the technical difficulties, folks. So now that we're finished, we're going to break out into some groups again. I'm going to have you guys write down a few questions that you have, and we can discuss them as a class. We're going to take maybe 5 minutes there. And then after we do some more of those breakout discussions, we're going to actually take this to the bedside and demonstrate this on some actual patients. Thank you everybody for listening today, and I will see you guys out in the field.